Good day. I'm Charles Loprinzi. I'm happy to host this particular session. Chemotherapy-induced peripheral neuropathy, commonly called CIPN, can have an enormous impact on a patient's quality of life following chemotherapy treatment. But at this point, there's no proven method of prevention available other than stopping the causative chemotherapy drug. Decreasing blood flow when there's a lot of neurotoxic chemotherapy in a patient's blood by cryotherapy or compression therapy has been an exciting topic over the last several years. This has led to the development of a new cryo-compression device that shows real promise as a means of decreasing or preventing chemotherapy-induced peripheral neuropathy. I look forward to this discussion that we're about to have regarding CIPN. Now we can get down to the topic at hand, and let's start off by discussing CIPN as a side effect in a little bit more detail. What does it mean to a patient, and what does it mean to a physician? And Anne-Marie, let me have you take off a little bit more from what you were just saying to go into a little bit more detail on this issue, please.
So here's the thing with side effects. They're either a nuisance or it's a big deal that requires either urgent care, the emergency department. And I think it's why this appeals to me as we're addressing it is because symptoms are cumulative within a patient. Even if it's a nuisance symptom, if you end up with 5 nuisance symptoms and then, a couple of serious side effects, it's all happening within one person. So as many of these things as we can address goes to making the quality of life better for every single patient. If you can take away some of those burdens with interventions that we know are going to work, that's important, because as many of them as we can get off, that there are some that are not going to be able to be taken away, at least while you're in active treatment. Neuropathy, unfortunately, I know can be, in a lot of cases, something that people may think it's going to go away once they stop treatment, only to find out a year later this is not resolving. And now you have a constant reminder of and an annoyance, and something that I would submit can be dangerous. If the neuropathy is in one's foot, it leads to a fall, and suddenly it's a far more severe problem. So this area I think is supremely important for us to be addressing, because it is seen as primarily, I think, a nuisance. Unless it's happening to you, then it's not a nuisance. Then it is absolutely affecting every aspect of your daily life.
From our audience, they may not necessarily even know what CIPN is. So maybe just some general definitions would help. So CIPN means, largely in chemotherapy, means a sensation. So a feeling of pins and needles, numbness, tickling, all different sorts of words have been described as the earliest symptom, which can progress to pain. That can start as something that comes and goes and progress to be something that's ever present. And as we think about it as a continuum, grade 1 would be comes and goes. Grade 2 is severe. Grade 3 is constantly interrupting your quality of life. Grade 4 is virtually disabled from the severity of the symptoms. And that's a very, very minimalistic description of how we grade peripheral neuropathy, but a good snapshot of what we're looking at. Very rarely, peripheral neuropathy can also result in motor dysfunction. So the strength or the function of the joint. In breast cancer with paclitaxel, that happens about 15% of the time, which obviously isn't the most common. It's a little bit more common with thalidomide, which has mostly fallen out of favor. We don't use it as much as we used to in the heme-based malignancies. My GI colleagues on the call can comment with oxaliplatin and how often it's seen there. And we see that it peaks with each dose of chemo a couple of days after, and then hopefully is tailing off with the next dose. But like Anne-Marie said, peripheral neuropathy is the side effect that worries me the most, because unlike low blood cell counts, where I have medicines that can very clearly rescue somebody, can even prevent it very predictably, nausea and vomiting, I have great advances over the last couple of decades that can keep patients out of trouble. With peripheral neuropathy, not only do I not have great solutions, but it can be a forever side effect. And so I think that just starting with those basic definitions is a great spot. And I had seen that Melissa had unmuted to speak to.
Yeah, so what I was going to say is it's really challenging because everyone's experience with neuropathy is so different. And in the beginning, when we were looking at this in clinical trials, we were using a lot of the grading system. And unfortunately, when we report, neuropathy, it sometimes undercaptures what patients are actually experiencing, because unless, like Dr. Graff said, that people are really truly having disabling symptoms, people sometimes will look at the papers and say, they're very low rates of grade 1 neuropathy. And that's really different for every patient. And patients' experience, even with what we might consider grade 1, could really impact their quality of life significantly. And, that's why I think we've made a push that in these trials to use patient-reported outcomes, because that's probably the most meaningful for patients. And it captures their experience a little bit more robustly than with the primary adverse events grading. It's also challenging. You're right. We don't have good treatment. We don't have great prevention. We've had many things that we've tried in the past and have been unsuccessful or have harmed patients. And, it's also when we're thinking about solutions, we're often thinking about pharmacologic therapy. And patients are really reluctant to take, medicines. They're already on so many, and all medicines have side effects. And patients are really looking for non-pharmacologic interventions. I know Anne-Marie could speak much more to this. And what people are doing out there in the community is, because this is such a feared symptom, could sometimes be extreme. And people are doing these things without any data because neuropathy is so impactful on patients' quality of life. So I think it's so important that we try and find interventions that are safe and are effective, and we have data to support their use.
So can I jump in there because of something that you said, Melissa, which is what patients are doing in the real world? And I know this because I keep seeing it. Everyone is directed. This is patient to patient. Each patient is directing another group of patients to places on Amazon to buy frozen gloves. And then it turns into this whole long conversation about which gloves are the best ones to buy or which booties are the best ones to buy, how to go to your treatment center with a cooler to make sure that you keep these things at an optimal temperature. And to the point you were just making, none of this has been studied. None of it's been validated. So it's kind of like the patient's Wild West out there. And frankly, I don't blame them because it's let me try to do something in the absence of no intervention that we know is working. So for anyone that is working on or trying to put together a clinical trial to prove what works, I want to stand and applaud, but I won't do that because that would just ruin the whole screenshot here. But I see what's happening out there. And for every person that puts out a suggestion on how a person can best deal with this, there are 10 other people that are adding their own 2 cents. And I'm looking at the whole thing with my research advocate hat on saying, no, we need to answer these questions scientifically so that if you're doing something, you're not just dragging a big cooler into a room for no benefit or extremely minimal benefit. So thank you for bringing that out because it is happening. I'm here to state to everyone on this panel and everyone that hears what we're discussing today, it's happening. Patients are doing this.
It's been said again, patient-reported outcomes is the best way to do it, not physician or nurse-reported. It's what the patient says is the bottom line answer. It took, I believe that for 30 years. It took a long time for that to come around to others because the scientists used to say it was what the doctor or nurse says. That's clearly not true. And that it can get worse as time goes on after you finish chemotherapy. There's something called the coasting phenomenon, that after you finish your last dose of chemotherapy, it gets worse, more particularly with oxaliplatin as opposed to paclitaxel. And on average, and it used to be thought that maybe that patient was doing fine, and they stopped the chemotherapy, and then 3 months later the neuropathy was worse. It was because of stopping the chemotherapy. But when we looked at the natural history of that with oxaliplatin, commonly given for colon cancer, that the slope of how things got worse in the 2 months prior to stopping and the 3 months afterwards was exactly the same, which in my mind just means it took 3 months from that last dose to get the final insult from the chemotherapy. And then things tended to get better. With paclitaxel, on average, things start to get better in the first 2 or 3 months right away. Not for everybody. It varies from person to person, and it can be a persistent problem for many, many, many patients there.
Yeah, so I just wanted to bring up a different perspective to what I think Anne-Marie brought up, as well as I think the kind of patients Stephanie and Melissa are seeing, because I think there are a whole group of patients out there who are trying to do their best to prevent neuropathy, but neuropathy is also one of those side effects that are not obvious to everyone. If you talk about hair loss from chemotherapy, everybody knows about it. But if you say numbness to a lot of patients, they're like, hey, I have cancer, I want to kill it. I don't care about numbness. Until the numbness actually kicks in. And then they're like, hey, you didn't tell me this is going to happen. And I was like, no, I told you this was going to happen. But with all the other 100 things I have to tell you when you first diagnosed with cancer, along with the neutropenia and the nausea and vomiting and the hair loss, then the neuropathy just falls off to the background. But because it's one of those long-lasting side effects, it's the thing that we see our survivors with all the time, and that's very hard to bring out. The other important point I think that both Charles and Melissa brought up was this issue about the differences in the way clinicians view side effects and the patients view side effects. And I think this is especially acutely important in the neuropathy space, because tingling and numbness to an average, and I won't say average as in it's any person, is very different from if you're a concert pianist who's going to get a neurotoxic chemo. But it doesn't even have to be a concert pianist. You could be a pastry chef and still have problems with neuropathy, and that affecting your quality of life. And therefore, these very subtle differences in the neuropathy itself is something that we really need to work towards quantifying this in a better way, so that even what is considered incremental or modest improvements is may actually make a big difference to some patients. And I think there's a lot of work that needs to be done there as well.
Thank you, Raghav. And as mentioned, there's numbness, there's tingling, and there's pain. And they're different, they're separate, but it can be hard for patients to differentiate them. And numbness can be a real discomfort, if you will. And how do you differentiate those things? Generally, it's numbness and tingling that come on first, and pain that come on last, but they do intermix with each other. We want to think about how to prevent this particular problem. But before getting to that, if a patient has this problem, has established chemotherapy-induced peripheral neuropathy, they are done with their chemotherapy drug, and they still have the problem, what do we have in our armamentarium for treating that particular problem?
So, many interventions have been tried, and almost all have been really unsuccessful. In terms of medicines that have data, duloxetine is helpful for helping with pain related to neuropathy, but really hasn't been so great at helping with other symptoms related to neuropathy. But, in the real world, patients are treated with so many agents to try and help with this, whether it's gabapentin or Lyrica or duloxetine. And often, in terms of the relief they're looking for, it's really not there. I've personally had some success with duloxetine with patients who've had a lot of pain related to their neuropathy, but in terms of patients who've had other symptoms,